Yes, good evening, everyone. I'm Michelle Batty, and I'd like to welcome you to the EUROGEN webinar series. So just before we get started, I'll take a couple of minutes to explain a little bit about what the European reference networks are and what they do. So EUROGEN are 4 European reference networks created by...
Devo ascoltare questo.
Please. Loredana, please mute. Created by the European Reference Network in 2017, and they cover most medical fields, but we deal with patients with rare urogenital diseases or complex conditions. And we're currently a network of 52 full members, so they're healthcare providers with highly specialised expertise located in 20 member states. So what do we do? Well, our aim is really to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for all patients with rare urogenital diseases and complex conditions. So they're generally all patients who need highly specialised surgery where the expertise is rare generally. So some of our activities, I hope you noticed at the slides right at the beginning, we do perform virtual consultations, and we use a secure IT platform that was specifically developed for the ERNs to use by the European Commission. So we can perform cross-border multidisciplinary virtual consultations in a very safe way. And that service is provided free of charge. So if you have a rare or complex case, don't hesitate to get in touch with us via the website, and we can arrange one of those virtual consultations with members from our network. We also have training and education activities like this webinar program, and we also have some highly specialised surgical training programs coming online starting from next year. We also have a patient registry. This is just being rolled out now across all our healthcare providers, and this will be incredibly important to capture the fragmented data on patients with rare diseases across the whole of Europe. And of course, that data will be very important for the future development of clinical guidelines, for example. So without further ado, tonight's webinar is on how to welcome patients with interstitial cystitis and bladder pain syndrome. And this is the second of our mini series of webinars on this topic, produced with ESSIC, which of course is the International Society for Bladder Pain Syndrome. And ESSIC is very kindly a supporting partner of the ERN, and we're delighted to work in collaboration with them. So now I will hand over to the Secretary General, who most of you will know. His name is Mauro Cervigni. Mauro, thank you very much for doing this series with us, and I give you the floor. Thank you.
Good evening, everybody. I'm Mauro Cervigni, President of the ESSIC, the International Society of the Study of Interstitial Cystitis, and it's a great pleasure and an honor to have organized this series of webinars into the ERN. One of them, this is the second the webinar proposed by the Society, is a delicate situation, how to welcome patients with AICI BPS, because as you know, those are patients with a complex and very sometimes very severe form of syndrome that should be approached by mainly by the physician, the doctors, but also from patient organization to have the possibility to be understood, because sometimes air problems or his problem are ignored by the majority of doctors that are not expert or are not involved deeply into this complex situation. Today we have 3 speakers, 2 from patient organization and 1 a doctor, and it's important to listen, to hear from them how to approach the patient with this problem. The first speaker is Loredana Nasta, is the president of in Italian Association of Interstitial Cystitis patient. The second speaker is Anna De Santis, that is she is EPEG, the European Patient Advocate Group representative, and also is one of the members of the directory board of the Italian Patient Organization, and due to the EPEG has been included also in the EUROGEN, the European Rare Disorders Patient Organization. Finally, we listen from Dick Janssen, that is an expert on BPS AICI, and is one of the members of the directory board of the ESSIC. So please, Loredana, begin your speech.
Good afternoon to everyone. Nice to see all of you. Yes, I am the president of the Italian Interstitial Cystitis Association. And first of all, allow me to thank EUROGEN Network and the ESSIC, the European and also the International Society for the Study of Bladder Pain Syndrome, AICI, to introduce the first time a topic that is so important to patients. How patient with suspected interstitial cystitis is received in a medical office, and how he should instead be welcomed. The aims of this second webinar is to draw up some recommendation mandatory for an excellent referral center for the doctors. We are going to analyze some critical points coming out from a consultation with the worldwide AICI BPS patient advocate, as well as interstitial cystitis bladder pain syndrome is a complex rare disease with a low prevalence that targets bladder and involves pelvic organs, muscles, and nerves. It has a slow worsening until loss of bladder function. The delay in diagnosis causes overlapping of multiple comorbidities and increases the severity of the condition. It occurs with urgency frequency syndrome up to 60 trips to the toilet day and night. Pain and hypersensitivity are nightmares that can turn patients' quality of life into hell. Pain, an invisible disease, difficult to measure and understand for people if you don't try it yourself. Often pain and discomfort are underestimated and don't taken seriously. Too often the doctors say it's all in your minds, all in your minds. These sentences has become a milestone in the AICI patient journey. But let's see what happens to the greatest number of people with these symptoms when they turn to a doctor.
Hello, good afternoon, everyone. So let's see, yes, how patients, according to a few interviews we conducted with our patient colleagues, that should be welcomed. So we have patients A and B that have been experiencing the following symptoms in the last 6 months: urethral, vulvar, anal, scrotal, muscles, and nerves pain, frequency and nocturia, urgency and dyspareunia. They get an appointment with their respective family doctors who, suspecting they might have AICI BPS, refer them to the closest interstitial cystitis reference center. They are received by a urologist and a nurse, and within 1 month get a cystoscopy with hydrodistension and biopsies done. After a few weeks, they get diagnosed with AICI BPS, and the urologist prescribes the necessary treatments, gives diet instructions, and suggests to seek psychological support. Since these patients have also referred symptoms related to fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, vulvodynia, endometriosis, gluten sensitivity, leaky gut syndrome, etc. All these comorbidities call for a multidisciplinary approach, and they get visited by other specialists in the same center. Well, of course, this will only happen in an ideal world, and so we welcome you to utopia, because the reality, unfortunately, is much different. So we had our patients' colleagues that have been paying for 12 years, that have been seeing a lot of specialists, and in 12 years they had no cystoscopy or any other bladder procedure done. Another patient was told by a urologist that you are somatizing. Well, another urologist said, I don't know how to help you further. Maybe you should see a gynecologist. A gynecologist said to a patient, you know, your uterus pushes on the bladder. I suggest we remove it. I mean, remove the uterus. Families don't believe to the patients anymore because the doctors say there's nothing wrong with them. A neurologist, for example, said to a patient, have you invented everything by chance? And a urogynecologist said, so ABT suggested ABT even though tests were negative. And a urologist suggested a partial removal of the bladder to a patient. Another urologist said, you're not going to die, but you will not get rid of it. So the reality that these patients felt is that the disease is at the center, not them as human beings carrying the disease. So we have here patients' wishing list, and this wishing list comes from the interviews we as an association conducted with our patients' colleagues from international AICI patients associations. Well, first thing, they want to be listened to. They want to receive info about the proper diet from clinicians. They want to be referred to a specialist in interstitial cystitis. They would like to be asked how AICI has impacted their lives. They want to feel empathy from clinicians, and this happens very rarely. They would like that this disease is not emphasized as an incurable disease because this might trigger suicidal thoughts in patients. And more, they would like to receive advice to see psychological support, because when we receive this kind of diagnosis, maybe, you know, our mind goes ballistic and we're not able to think clearly. And they also would like some respect for privacy during the procedures in hospitals and not having people passing by at all times. They also would like to be told what they can learn to do by themselves, like, for example, bladder installations. And last but not least, they would like to be told that they're not crazy. Oh, I can also put myself in it. Since I suffer from AICI, we want to be told that we are not crazy. Thank you.
Undoubtedly, the criticisms who Hannah just described are common in the rare disease community, and they have a dramatic impact on the AICI patient journey, as the data from rare diseases impact collected by urologists shown. In fact, it takes on average 7.6 year in USA, and 5.6 year in UK to receive a proper diagnosis. And that's not all. In order to get the proper diagnostic, a patient typically visits up to 8 physicians, 4 primary cares, and 4 specialists. And that's not all yet, receiving 2 to 3 misdiagnoses. The AICI patient experience, according to patient surveyed in a project carried on with Ministry of Social Policy, Orphanet, Italian Rare Disease Federation, financed by Big Pharma, shows 31.58% received the diagnosis after 5 years. 10.53% in 10 years, and 36.84% over 10 years elapsed between onset symptoms and correct diagnosis. 78.33% received before wrong diagnosis with consequent ineffective therapies, including unnecessary surgeries. Really, there are some obstacles to lead to AICI diagnosis, confusable disease that complicate the diagnosis. Urinary tract infection is more common confusable disease. It should be considered a comorbidity. Range and severity of symptoms, the definition nomenclature isn't uniformly defined. And the last but not least, the lack of awareness among the medical community has led to delay in diagnosis. The delay in diagnosis leads to the worsening of symptoms and the appearance of comorbidities. I would like to show you the AICI patient journey performed by EUROGEN network and EURORDIS as ideal journey for AICI patients. Thank you for your attention.
Thanks to both of speakers. That then we will have time for discussion. Now I would like to introduce Dick for his presentation. Please, Dick.
Hey, thanks everyone for the invite to share my views as a doctor treating bladder patients. And I think this is a really important topic to address, because eventually we as doctors are here to treat our patients, and in a complex disease things can go wrong, and I hope to share some tips and tricks from my own experience to help you improve healthcare and have more patient satisfaction with healthcare. So a doctor's point of view, I think it's well written in the guidelines. So treating and diagnosing and treating bladder patients requires a holistic approach. So it's a complex disease. Often we have many different treatments, but they're not efficacious in everyone. So it's really a tailor-made diagnosis and treatment plan. It's multidisciplinary in nature. It often includes dysfunction of multiple organ systems, so it's not just a bladder disease. It develops also other problems within the pelvic area, and it also coincides also with psychological and social dysfunction. And these are things that affect the quality of life of the patients, and therefore they have to be addressed to obtain a successful treatment outcome. And again, many of the multiple organ systems, they are cross-linked, they are involved, and one thing affects the other one. So addressing them is essential also to carry out a successful treatment plan. So what goes wrong in practice? Well, of course, our patient representatives already talked about this. Patients often do not feel understood and or dismissed by healthcare providers, and this is a very common thing that I encounter. There's still a very monodisciplinary view on healthcare, and it's also applied to the problems that these patients represent or show. And healthcare providers have often a very narrow view. So this is only in my street. This is what I do, and I will not look at a gynecological tract or at a gastroenterology tract or a pelvic floor dysfunction. That's not my problem. I'm here as a urologist. I diagnose and treat bladder stuff, and my expertise ends. And for this type of problem, it's really not helpful if you have this monodisciplinary view. And this often then will result in inadequate treatments and dissatisfaction in patients, but also in healthcare providers if you have this type of mentality or view. It results in negative views on healthcare providers by patients, but also the other way around. It also adds to negative views on patients by healthcare providers. So you end up in this really dissatisfaction type of healthcare interaction with your patients. And that often leads to healthcare shopping by patients, and for good reason. And this also results in high costs for patients and society, because a lot of things are repeated, a lot of things are sort of neglected. So this is not my problem, you should go there, and then they have the same thing and the same mentality, so patients aren't getting anywhere, and therefore they shop, and it's a lot of burden on society and healthcare and funds as well. So and this is a routine that's very common in usual medical practice, but for these types of patients, multidisciplinary care is essential. So basic number one, I say, earn the trust of your patients, which is building trust. It's really important because there's very often very negative associations with healthcare by those patients, and for good reasons. So I always discuss these past negative experiences with the patients to address these points. And so I've asked also what the treatments they have already gotten, the problems that they have had, and there's multiple reasons. I also don't want to suggest a potential solution for a treatment that has already failed previously in their healthcare plans. Discussing these negative experiences can help break this cycle of distrust. And as I said, when discussing this, I always try to be respectful of my colleagues, but I will not defend them to the end. There's a lot of colleagues, I say, that make wrong decisions, and they're not perfect at all. So I will be respectful for them, and it's complex disease to treat, but you don't have to defend them till the end. So sometimes people make wrong decisions as clinicians, and there's also sometimes has to be addressed. One key aspect, and this is what I come very close to, you can saw it in the presentation, many patients come here and find that the healthcare providers get an attitude of them being crazy. And it's so undeserved and also untrue. So I say never deny a patient's pain. Whatever the underlying causes, pain is pain. Every type of pain, if it's biological, if it's due to sensitization processes, even if it's emotional, it's all sensed within the brain, and pain is pain and should be treated adequately. And the pain in bladder pain syndrome is multifactorial. It comes from organ inflammation, e.g. bladder problems. It comes from pelvic floor dysfunction, myofascial type of pain. Sorry for the misspelling. It comes from neuroinflammation and crosstalk and sensitization of pain pathways, including centralized brain pathways. So your brain really alters when there's chronic pain involved. And people should acknowledge that people should not deny that this pain is real for these patients. Also, it helps you to understand that the pain, therefore, often does not directly correlate with the bladder inflammation or the tissue damage. But it means that the pain is not there and should not be treated adequately, because all these other processes are also involved. It's very important when I think that someone needs to be their healthcare coordinator, and it should be someone with experience within these types of problems. So sometimes even when I have said, well, in my center there's no anesthesiologist. So if I refer a patient to for a pain clinic, I'm the one that does the healthcare coordination. I never said, okay, I'm going to refer to the pain anesthesiologist in a different pain clinic, and I will say, well, and then I'm rid of you. I will get rid of you or anything. No, I refer them and say, and then afterwards you can come back and see what the results are. And so you need to perform this coordination function, because if you rely on just the first line healthcare, like general practitioners, it's too complex for them to understand this type of problems, and they are not equipped to handle this type of healthcare coordination for this complex disease. And I think it's very important for you also to show to the patient that you're willing to be their healthcare coordinator in dealing with their problem. And again, what does this patient management team can look like? I mean, this is this cascade, and this is a slide that I've used quite a lot, but this is just to show you how all these cascading problems end up affecting multiple organ systems, also help creating sleep disorders, psychological dysfunction, social dysfunction, sexual dysfunction, and all those kinds of things. And these all are part of the disease, all part of the symptoms. And there is not just one healthcare provider that can deal with all these problems. So therefore, this coordinating position is, I think, very important. You have to have the context. You have to know to refer to the specialist once they are, well, required or indicated. So let's look a bit on diagnosis. How to explain a complex disease to a patient. I always suggest not to be this distant doctor. I mean, it's very, I hate that mentality, like there should be a very large distance between the doctor and the patient. This patient has a real problem, it has a real emotions and everything. So a bit of empathy helps a lot in getting a trustworthy relationship with your patients. You don't have to invite them in your home, but you can be, say that you're personally affected by their problem and show some empathy. And some things I think help in explaining the disease to what they are, what the underlying causes are of their symptoms. And when I take a patient history, you can be the distant doctor and say, okay, I'll ask you a lot of questions and I will not comment on why I'm asking this question because I am the doctor and I will, it's only relevant for my own perception of my diagnosis. It helps if you take a patient history and asking specific questions that you explain why you ask these questions. You can actually explain the pathophysiology to a patient while you're asking these questions. And you can use relatable metaphors to explain to a patient, okay, I'm asking this question because this is some things that we see a lot in our patient groups. And if the patient understands why you're asking these questions, then they will learn to understand the mechanisms and correlations behind their symptoms. And I think education and patient education and getting them to understand what's going on is really important to help them get control over their disease. Some examples, when you ask very personal questions, such as the presence of dyspareunia or sexual problems, or other vaginal problems like lichen sclerosis or defecation problems, these are very personal questions for a patient to ask. It helps if you immediately explain why you're asking that question. For instance, because of pelvic floor dysfunction, and I want to I do an inventory on how far or how much your pelvic floor is involved in this problem. Then it really understands. It leads to a patient understanding, and it really removes uncomfortable feelings in a patient because it's, oh, this is the reason why he's asking these sensitive questions. So it helps you a lot also in connecting with your patient and be able to, without embarrassment, ask these difficult questions to a patient. And in explaining your diagnosis and your treatment plan, a picture says more than 1,000 words. I really advise to use models or images for explaining patients what your diagnoses are, what type of problems that you are investigating, or what your treatment plan is going to be based on imaging. It's really highly educational for a patient. Some other tips and tricks. Better patient, a lot of Europe says, well, everyone requires cystoscopy. You can do this on the OR, but sometimes we also use a lot of office cystoscopy to inventorize if there's any inflammation in the bladder, any harder lesions, and so on. But there are some tips and tricks that you can actually help because we want to do the least amount of harm to get the most amount of information. So I advise for the least amount of harm is to advise to use flexible cystoscopy when available. I always advise if you have a conscious office cystoscopy not to overfill the bladder and keep it short to reduce the amount of pain that you I will not fill until I have a bleeding bladder because it creates a lot of pain for a patient. So I will not try to overfill. If I see an honest lesion, then I know what I'm looking at and I don't need to fill it much further. A really key, what I would say suggestion is to do cystoscopy with the patient lying flat in their bed. A lot of clinics still have do cystoscopy when patients are in the knee braces and so on, and it really contracts the pelvic floor. But if you have a patient lying flat, it relaxes them a lot more. It relaxes their pelvic floor a lot. So introduction of the scope is much more comfortable for a patient, and it's much less traumatic for a patient. And even if they have pain during the cystoscopy, for instance, when you insert the scope or anything, if they lay down, the effects of it with potential problems like like collapse or something is much more, the risk is much more reduced if you have a patient lying flat on a bench. You can, if needed or indicated, use lidocaine 2%, 30 mL to instill into the bladder 20 minutes prior to the cystoscopy. You can also, if there's any pelvic floor overactivity problems, you can use a diazepam sub, or you can also use a vaginal tablet. You also use an enema 30 minutes prior to doing the cystoscopy. If there's really anxiety, oxazepam will work. And if it's like a really problematic patient, you can actually use oral midazolam for mild sedation 30 minutes prior to doing the cystoscopy. Remember that if you do the last one, it's sedation. So have someone present to take the patients home afterwards. Also have them laying in a bed to sort of revive from the procedure. And after this, the midazolam is fully worked out, and the patient can safely go home. So for treatment, well, it's a heterogeneous disease with heterogeneous patients, heterogeneous symptoms, and heterogeneous treatment results. The treatments have a very large variation in efficacy between different patients. And also we know that treatments affect each other. For example, you have much higher success in having pelvic floor physiotherapy when there is pelvic floor dysfunction, when you have adequate pain management. Try to relax your muscles and do these treatments while they still have pain. It's very difficult to relax your muscles when there is pain involved. So these two strengthen each other. So treatments do affect each other, and this should also be accounted for. A traditional step-by-step approach that is done in many types of diseases, like doing one treatment at a time, is often inadequate because it's multi-problems. So advice that these patients are often in a sort of vicious cycle, and always advise that it's part of the holistic approach, especially in the starting phase, to map out all the symptoms and treat each one when possible. And so you get multi-targeted, and this more effectively breaks this vicious cycle that these patients are in. I would say if you cut a vicious cycle in multiple places, the effect will be much more efficacious than doing only one cut at a time. So this is sort of an example of a holistic, multifaceted treatment plan for a patient. So you can come with the bladder inflammation, the pain treatment, the pelvic floor physiotherapy, so looking at the pelvic floor, UTI prevention, psychology, and so on. And you can devise a treatment plan according to your holistic approach. So what then is also important is to look at treatment evaluation. So every different treatment has a certain set of time required to evaluate if it's efficacious or not. And I would advise you always to look at what is the minimum time that we can actually, with great certainty, evaluate if a treatment has become successful or not. And try to limit this time as low as possible to prevent over-treatment or applying treatments that are not effective and used for a very long time, often not needed. Not everything works in every patient, so you should evaluate these treatment results timely. And I think this is really important because I see a lot of patients on therapy for a long time that have no effect on them. Anticholinergic, sometimes for a very long time. They stop them. It doesn't do at all anything on the symptoms, but they've been using them for years on. So evaluate treatments when possible, at the earliest time when possible. And once you have a successful tailor-made treatment plan, it's always very doctor-like to start slashing in treatments, like maybe we can stop this and maybe you can stop that. In better patients, when in chronic pain patients, it's very key to provide stability. Because a lot of these things are slow processes for improving. So the longer you keep a patient stable, the better it is for improving physical and psychological issues. So not slice too quickly in these programs. Sometimes it takes a half a year or a year on the same treatment plan, but just to get a patient to trust their body again, and also give these neurological problems like sensitization problems, they take a long time to reverse. And so don't slice too quickly. Stability is key, especially in the first year or so. And then after they're stable and they have some trust again, the psychological issues, they're not scared too much from relapses and those kind of things, then it's time to discuss with the patient how maybe we can stop with this therapy or maybe another therapy, and then step by step you can reduce until you get the minimum required amount to keep a patient stable. So as a take-home message, I would say for myself, treat your patient as it was your family member. So do that dedication and show some empathy and understanding what the patient comes from, the prehistory with previous healthcare providers, the bad experiences. Understanding is important, and acknowledging that this is still a problem in daily practice. Apply a multidisciplinary holistic treatment, diagnostic and treatment approach. I think it's important for effectively treating BPS patients. For a successful outcome, the patient should know what and why they are doing types of treatments. So patient education is essential for a successful treatment outcome. But this is not a one-size-fits-all. Stratify your patients with your treatments and evaluate them timely. And overall, improvement of quality of life is the most important treatment goal. It's a chronic disease, and you should be able to try to get as much quality of life as possible from each individual patient. So I thank you very much for listening, and I think it's time for questions now, isn't it, Mauro?
Thank Dick for your presentation. That is really interesting from a physician, and to how to approach a complex patient like BPS-IC. I would like to make some comment on what we heard from all of you. The first point that you focus obviously is the pain. The pain is the crucial moment of the patient request, because urgency or frequency or nocturia are common lower urinary tract symptoms that sometimes urologists they approach with the patient, but associated with the pain, as in the situation like BPS-IC, is one of the more devastating situation with the impairment of the quality of life. I heard about diagnosis that is fundamental. I'm absolutely agree, and unfortunately, the diagnosis can arrive very late in the final definition of the problem of the patient. We heard that some patients, they arrive to the final diagnosis after 5 to 7 to 8 years. It's the same, if you can reflect, it's the same as the pelvic endometriosis. It's quite similar with the vulvodynia. They have a similar delay on diagnosis. Why? Because the pelvic syndrome, the pelvic problem are very complex. As Dick said, there is a kind of interaction among organs that can interfere with the evaluation, and also can interfere with the function of different organs among them. Another important aspect you outlines is the sex and the dyspareunia, because it's a very delicate situation, but obviously a doctor or also a patient organization have not should, but is obliged to approach this problem that interact deeply with the quality of life of the and interfere with the personal feeling of the patient. But sometimes I heard from also from colleagues that they ignore the problem because it is very embarrassing sometimes. And obviously, it's really important that the doctors they create a trusting situation among them. Finally, the problem of treatment. The problem of treatment is another important and intriguing aspect of the situation, because it's mandatory that should be multifactorial, that should be with the multimodal approach and involving several specialists. It's important in female patient the evaluation of pelvic floor, because it's very common that sometimes there is an hypertonic pelvic floor that is related to the situation of urination and as well as the defecation. This is one of several aspects that you pointed out in your presentations, and I would like to see, first of all, if there are some chat from the participant, or no one chat at the moment, no answer. First question is to the two previous speaker, to Anna and Loredana. As a patient organization, how can you think we could improve the approach to the patient? Because obviously, if a patient go to an expert on the field, it's more easy and more facilitating also the definition, the diagnosis, and also the treatment. But how can, as a patient organization, you can start a program or educational program with the doctors, family, or I mean, as a general practitioner or specialist, they are the referral people that you as a patient organization, you can stimulate the interaction.
Hi, thank you, Professor, for this question. We would like so much to involve the general practitioner, of course, because the general practitioner is the first doctor to which a patient go. And so, but it's not easy, because in Italy, for example, but I know that there is the same situation in other countries. The general practitioner in Italy is divided to a region. We in Italy have 22 regions. And so it's not easy to make a program, a plan to education, to educate the general practitioner to the national level. And so we will do 22 plan action, 22 projects to approach and to educate the general practitioner in each region. And so it's not easy, but I think that the first doctor that could be and should be educated is the general practitioner or family doctor. I don't know, it's a different roles in several countries. And the second one is absolutely the referral center, because the experience in Italy is that unfortunately not all referral centers are at the same level. We have some expert in some referral in some region, but not in all regions, and so it's very critical situation. But I think that this is the same in every country. So no.
Okay, now there are some questions from the participants. The first question is: the cost of non-diagnosis and seeing multiple doctors for many years plus wrong treatments must be costing countries a fortune in wasting resources. This is absolutely right, and we can take care about this critical situation. The second question is, I would suggest that AICI BPS doesn't coincide with psychological and social dysfunction. It causes it. It causes it. I agree again, because yes, obviously I think we all agree on this sense, this comment. And the third question is, how can artificial intelligence help in diagnosis and treatment of AICI BPS? This is a question for Dick. Dick, do you think that artificial intelligence can help in diagnosis in those patients?
I say for now, artificial intelligence is quite limited. There are some programs also presented in last ESSIC last week in New York that might aid in discovery of HaDEA lesions, for instance, so an aid for cystoscopy. But again, because it's such a individual approach, you have to find out what the patient wants for treatment. So it's a very personal dialogue with the patient, what they want. There's very treatment responses. So I think for the results for AI is when there's very systematic things like prostate cancer. It's very systematic. You have a Gleason score and those kind of things. You have a biopsy and MRI and those kind of things. But this is difficult because there's many different types of problems. Symptom severity, symptoms are often very subjective. Pain is very subjective. So I think for AI, it's very complex to understand this. I think this is really where the doctor and the interpersonal relationship with the patient comes in to say, okay, what's the best treatment plan for the patient in front of you? And it's an individual, and what you do with the patient and eventually what the program is and what types of treatments they want or how they respond to it is very individual. So I think for AI, it's very difficult to interpret this personal level in diagnosing and treatment of a patient. I would much more in this moment want to improve like the knowledge among physicians, GPs, and so on, so that actually that there will a lamp bulb be or will be lighted up once they say, well, this patient has sort of UTI or urinary tract infection type of symptoms, but negative cultures and so on, and there's pain involved. There's something wrong, and if they don't think about that it might be something else instead of urinary tract infections, then you have to think about it as a sort of a red light bulb to say, okay, maybe this is something else. I've heard of something like bladder pain syndrome, and there maybe are specialists that can deal with these types of problems. So detection and knowledge amongst healthcare providers is, I think, and patients themselves is very important at this moment.
Thanks. Another interesting question is, while many patients have complex comorbidities and see several different specialists, none of these doctors, even the same hospital, talk to each other. How can this situation be improved? Who want to answer this? This a very real situation that there are some hospital that they have in which the patient arrive and is evaluated, and first by urologists, by gynecologists, rheumatologists, and none of them they talk each other. How can this situation be improved?
Well, I can comment a little bit on that. It refers to that mono-specialized type of approach. So I'm a urologist and I only do the better thing, and I will not look at any other thing, and then I will say, well, I cannot help you anymore, and I'll get rid of my patient. Like we now done in the Netherlands, we made a multidisciplinary guideline for chronic pelvic pain, which involves all the specialists involved, anesthesiologists, gastroenterologists, gynecologists, and we're setting up pelvic pain teams. You have to form a network where actually there is a dialogue, and there is also a referral site for urologists or gynecologists that don't have this network to refer you to. So there's actually some in that guideline. There's also some advices for general practitioners and other specialists. Okay, when should I refer to a pelvic pain healthcare team? And this is when the biggest example is when there are multiple organ systems involved. Then you have to organize this. You have to form a healthcare network, and you don't have to do it in every clinic, but at least you have to do it in every large region. There has to be one clinic that has to pick up this network and get on with these patients to welcome them. So that's my advice, and that's how we're now doing it in the Netherlands.
Okay, and this is another question just for Anna and Loredana as a patient organization. How do you ensure that patients feel understood? Is often the time available for a consult is short for a complex problem. What do the patient use to refer to you? They feel understood and they refer that the office visit is too short for their complex problem? Microphone, please. Microphone.
Yes, I know. We know that this is another big problem. The problem is the time that the doctor can dedicate to the patient. In fact, for this reason, we auspicate, we hope that in the future the medical office is only dedicated to the AICI patient. This is the only way to get to offer a complex and adequate assistance, adequate care to the AICI patient with the pelvic pain, chronic pelvic pain, patient with pain. A medical office dedicated to this patient, and so in this case, the doctor can take an adequate time to offer to this kind of patients.
Yes, what I can add from my side, is that the feeling is that the patient didn't have the time to ask all the questions they wanted, and because maybe the clinician didn't illustrate what was going to await ahead of them, what is going to happen, and maybe they only had 20 minutes, half an hour with the doctors. They felt a bit at a loss. For example, I received a phone call from a patient that was recently diagnosed because she didn't know how to ask regarding a treatment, but I said, I'm sorry, but I don't have the qualifications to advise you on a treatment, but because she felt she didn't have enough time to ask. Over.
Oh, Mauro, you're muted.
Okay. The time is finished. We arrive on time, finish on time. I would like to thank deeply all the speakers for excellent presentation and for a very interesting approach to those complex. We will have a rest for the summertime, but we will start again the ESSIC series on September. And it's a really pleasure for us as a society of interested on this complex situation and syndrome. to be part of the ERN that is doing a really, really great job. Thank you all. Bye. Bye.
Thank you.
Thank you.
Thank you, everyone.
Thank you very
Thank
much.
you. Thank you. Bye.
Have a
Just
good
quick
night.
before we go, just a quick reminder to everybody that you'll get the attendees, you'll get a survey straight after this. Fill that in. Great. So I'm just going to mute everybody. You'll also get hopefully get a certificate. If you have a problem with that, please let me know. This will be recorded and will be on our YouTube channel tomorrow. And yeah, we're having a break now. We've got one more webinar next week, and then we restart on September the 6th, I think it is. So yeah, just want to give those quick messages. So thank you to everybody, all the presenters and everybody for this evening, and everybody have a good evening. Thank you.
Thank you. Bye.
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 Bye. Thank you. Thank you.